Hello, and welcome to the Multidisciplinary Team Approach to Treating Bladder Cancer. Before we begin our program, I'd like to go over some quick housekeeping tips. As a participant, you are in listen-only mode. If you have a question for any of our presenters, please use the question box in the GoToWebinar section on the side of your screen. Type your question into the box as you think of it. It's best if you can ask questions that are specifically related to the content of this webinar. We'll be answering as many questions as we can at the end of today's program. This webinar will be recorded and should be available along with the transcript and the presenter's slides on bcan.org and our YouTube channel within the next week or two. You will also be getting a link to the recording tomorrow. You'll be asked to complete a short survey when today's program concludes. Please be sure you take a few moments to do this. Your opinion on today's program is very important to Beacon. Please call Citrix GoToWebinar for any technical support problems you have. Their number is in the gray box on your screen. Welcome to the Multidisciplinary Team Approach to Treating Bladder Cancer, a patient insight webinar from the Bladder Cancer Advocacy Network. We'd like to thank Bristol Myers Squibb, the EMD Serono Pfizer partnership, Ferring, Genentech, Photocure, and Merck for their support of the Patient Insight webinar series. My name is Stephanie Chisholm, and I'm the Director of Education and Research at Beacon. I'm joined today by three experts from the University of Washington in Seattle: urologist Jonathan Wright, oncologist Dr. Petros Grivas, and radiation oncologist Dr. Jay Liao. Welcome. It's a pleasure to have you all with us. They're going to explain the benefit of involving a multidisciplinary team in your care. And we know that that's not always available to every patient in every community. So remember, if you have questions, write them in the question box and we will answer them at the end of the program. Let me first introduce our speakers. Dr. Jonathan Wright is the medical director of the University of Washington Medical Center Urology Clinic. He's an associate professor of urology. He's also an affiliate investigator at the Fred Hutchinson Cancer Research Center. Dr. Wright completed his MD at the University of Washington, and he's a member of many professional organizations, including the American Colleges of Surgeons. He serves on the executive board of the Washington State Urology Association. Dr. Wright is also a member of the National Comprehensive Cancer Network Bladder Cancer Clinical Guidelines Committee. So welcome, Dr. Wright.
Thank you so much.
Dr. Petros Grivas is an oncologist at the Seattle Cancer Care Alliance. He's the director of the University of Washington Medicine's Genital Urinary Cancer Program and a UW Associate Professor in Oncology. Dr. Grivas earned his MD and PhD at the University of Patras in Greece. He's board certified in oncology and internal medicine, and he lectures internationally and pursues community outreach, leads studies, and publishes novel research. Welcome, Dr. Grivas. It's nice to have you with us.
Thank you so much for having us. It's a pleasure.
Great. And Dr. Jay Liao is a radiation oncologist at the University of Washington Medical Center and the Endocrine Tumor Center at the University of Washington Medical Center and the Seattle Cancer Care Alliance proton therapy area. He's an associate professor of radiation oncology at the University of Washington. He earned his MD at the University of Michigan. His clinical and research interests include skin cancer, melanoma, and head and neck cancers, as well as genital urinary cancer. So it's nice to have you with us, Dr. Liao.
Thanks, appreciate it. Excited to be part of this.
Great. So I am going to turn the program over to you. So you guys should be able to change the slides.
Thank you so much, Stephanie. We're all very excited to be here, and thanks again for having us. The objectives of today's webinar include an introduction to the infrastructure of our University of Washington and Seattle Cancer Care Alliance Bladder Cancer Multidisciplinary Program that is consisted of urology, medical oncology, radiation oncology, pathology, radiology, and a number of other professionals and experts, colleagues, coordinators, nurses, and etc., who conform a team that brings together different expertise and experience. We're going to also review a few simulated patient cases as examples, just to highlight our multi-specialty interdisciplinary approach in the clinic and give an idea of how we function as a team together at the same place at the same time. We're also going to highlight some very interesting clinical trials. It's not an exhaustive list, but definitely a representation of what is happening right now in the field of bladder cancer. And I think it's really, really important to highlight the exciting research, which is very relevant to patient scenarios and patient experience. Moving on to the next slide, I would like to start by discussing overall the landscape of treatment options for patients with bladder cancer. And as you see on the left part of the slide, we definitely consider surgery, specifically radical surgery, as one of the cornerstones of treatment for patients with bladder cancer, as well as patients with upper urinary tract urothelial cancer that originates in the kidney, pelvis, or the ureter. And also rarely cancers of the urethra can also be treated with multimodality approach. Surgery can be part of it. Dr. Wright, who's sitting next to me, he's one of the main representatives from the urology team, and pretty much we have a very robust team of well-qualified expert surgeons who know bladder cancer in and out, and definitely communicate with us to try to find the best option for the right patient at the right time. On the middle part of this figure is what we call systemic therapy. The term systemic therapy has to do with the idea that these drugs, these agents that we use, are given in the whole body, the whole system. It's not only a focal treatment as opposed to surgery, which applies to one part of the body, or even radiation, which applies to one particular part of the body, but goes in the entire system, entire body. So that way we call it systemic therapy. There are various examples of systemic therapy, the most common of which is chemotherapy, and we're going to discuss a little bit about that. Chemotherapy has to do with the introduction of chemical agents that target directly cancer cells, and they have various ways that these drugs work, what we call mechanism of action, and the goal is to kill directly cancer cells. And chemotherapy is usually given through the vein, IV, but there are also some medications that are given orally through the mouth, and these can be chemotherapy agents. But for bladder cancer, most chemotherapy is given through the vein, intravenous administration. Now, it's very briefly to mention that chemotherapy could be given inside the bladder. This is intravesical, not intravenous, and there are very particular situations where this might happen, especially for superficial forms of bladder cancer, what we call non-muscle invasive bladder cancer. And Dr. Wright is doing that sometimes in patients in the clinic, but chemotherapy is usually intravenous, goes on the whole system, systemic therapy. There are other examples of systemic therapy like immunotherapy. We're going to give some examples in the next few slides about how immunotherapy works. And in one sentence, it can stimulate the immune system, so it can indirectly target cancer cells by stimulating, by triggering and augmenting the immune system response, so the components of the immune system can go out there, identify, discover, and kill cancer cells. There are other therapies that go in the whole system, like orally administered agents or intravenous administered agents that are targeting specifically genes and proteins in the cancer cells. We call these targeted agents, which are kind of a magic bullet scenario that try to target specific elements of the cancer cells. And of course, we have bone-targeted therapies, as well as other approaches that go through the whole system, inhibit new blood vessel formation, etc. So all of those agents go under this category of systemic therapy. Radiation therapy, Dr. Liao is sitting also next to me, is a very important modality which is being used more and more nowadays, and has particular indications. In our particular third case, we're going to show you examples of how radiation therapy is being used. There have been multiple advances in the field, and Dr. Liao can comment on that, about how radiation therapy has become more safe over the years, more targeted, and how we utilize technology in order to enable safe and optimal delivery of radiation therapy. And we're going to show you some examples of that from our own practice. So all these specialties are very important and all together can have the right application for the right patient. So overall, I would say that bladder cancer management definitely represents an unmet need, a highly unmet need. As you can imagine, there is a variety of complex decisions that need to be made for patients with bladder cancer and urothelial cancer that can arise from other parts of the urinary tract. We have to make sure we have a very good and accurate diagnosis, taking into account history, physical exam, radiology, imaging findings, pathology. We have to make sure we have adequate clinical staging, cystoscopy, looking at the bladder is part of that. Deciding on the appropriate modality of treatment, chemotherapy, radiation, surgery, combination or sequence of those modalities are important. And what we need nowadays is to find what we call biomarkers, which are some clinical or biological factors that enable us in the future, help us select the right treatment for the right patient at the right time. And that's what we need to do to find the right treatment at any point of time. Many patients have multiple complex needs, other medical issues beyond bladder cancer that we have to take into account. As we say in the clinic, we treat the patient, not only the cancer, but the entire entity, the entire physical entity of the patient. And we have to take into account all physical, social, psychological beliefs, expectations, all the aspects of a personality as well. And many physicians and providers are involved in this multidisciplinary care. So the question is, how do we align and form a care team to provide the best treatment for the right time for the right patient? So Dr. Wright is going to take over right now to drive us through that context and structure of the bladder cancer multispecialty clinic. Jonathan.
Thanks, Dr. Grievous. So it is, as Petros mentioned, it's a huge challenge to manage all of the challenges that that bladder cancer patients and clinicians face. And so what we set up now 5 years ago is called the Bladder Cancer Multispecialty Clinic. And our goal was to bring all of the teams together in one place at one time with the patients. Now, clearly, this, as Stephanie said at the beginning, this isn't feasible at every place, but we set up this model and have found it to be very highly functional for both us and for the patients. And you can see on the timeline where we started out doing it bi-monthly. It wasn't long before we had to add another the fifth Tuesday, and then for the past 2+ years we've been doing this weekly and are talking about expanding it even further. And as Dr. Grievous kind of highlighted, there are a number of different groups participating in this. We have the urologists, the medical oncologists, radiation oncologists, and this is crucial. We involve specific expertise in pathology and radiology, where we're able to actually look at the biopsies. Many of our patients had biopsies done at another site and then are referred in for evaluation. We review those in real time. We look at the x-rays, CAT scans, etc. that have been done. As Dr. Grievous mentioned, we have several nursing team members that are available and lots of other services. It truly is a team approach to taking care of bladder cancer patients. And this is how the schedule is set up. A patient arrives, and for the first hour, there is a history and physical done. Some of the, and this could be done by one of the faculty, one of the physicians, one of the resident training doctors, or a fellow. And then the patients are actually given a break for an hour. And during that hour is when we all sit together in one conference room, go through each case, go through each x-ray, each biopsy, and take a look together and try to figure out what the treatment options are and see if there's a specific recommendation or a couple of different treatment options to propose to a patient. And then for the last 2 hours, it is a half-day clinic. Patients are seen by each one of the services: radiation oncology, medical oncology, and urologic oncology, and we engage other services as well, stoma-therapy and physical therapy as needed. But this is the basic system that we've set up for what we call BCMC. Dr. Liao is going to mention we've been looking a little bit at our own experience and what we found with this.
Hi, so it's been really exciting seeing the growth of this clinic over the years. And typically radiation oncologists in many settings have had a little bit more ancillary role in the management of bladder cancer. And I feel like it's probably been underutilized, where there are many cases of where radiation oncologists and the role for radiation, chemoradiation could have a larger role. So recently we took a look at the outcomes of some of our patients that were referred from outside institutions. So this is just a subset of the patients that we've seen, and we took a look at 201 patients that we saw over the course of a number of years from 2014 through 2017. And we were looking at how this experience with the BCMC helped to impact on patient care. So after a review in BCMC clinic, we found that there was a significant number of situations where there was a change in interpretation of imaging findings, whether it's CT scan or MRI scans, PET scans, about 24% of the time, which is about 1 in 4 patients. We also have expert review of pathology that we do in real time with our genitourinary pathologist at the same time as the clinic is conducted. And from this review, there was a significant proportion of cases where the pathology there was also a significant change in interpretation, about 29% of the time. And many times this would lead to recommendations for additional diagnostic workup, whether that was labs or biopsies or additional scans, almost half of the time, about 41% of the time. We found that this actually made a big difference as far as what the ultimate treatment recommendations were for patients, and the actual staging compared to the initial impression was changed about 27% of the time, which can make a big deal as far as the overall treatment recommendations for a patient. And this led actually to an overall modification in the overall treatment plan more than half of the time, so about 60% of the time. And what we try to do a good job about is we realize that many patients may live far away and have ways to come and would not necessarily be able to have treatment with us, but we try to coordinate with the referring teams and the care teams locally to help to convey what our recommendations are if folks end up having treatment closer to home. And fortunately, subsequent treatment plans for what was recommended was most of the time concordant with our recommendations from BCMC clinic, the vast majority of the time, about 92% of the time. So we found that this experience really made a huge impact on patient care, and we hope leads to improved outcomes. And we found that a couple notable things stood out. There was a recommendation for the addition of neoadjuvant chemotherapy, which is chemotherapy before surgery, in a larger proportion of cases compared to what the initial recommendations were. We also found, and this is exciting for me as a radiation oncologist, that we offered more often bladder preservation treatment. So the utilization of chemotherapy and radiation as an alternative to surgery or radical cystectomy. And this overall with the patterns of practice is not done as widely in the United States as in some places, and is something that we could probably do more in select patients that are good candidates for this. In some cases, the overall game plan with the patient was modified as well. So there was a change from what was felt to be possibly curative treatment, where we felt it was more appropriate to provide palliative treatment or supportive care. So we definitely have been finding that there's a big change in practice recommendations, and we're going to be looking closely at how this hopefully helps to improve treatment outcomes for patients.